Hi, thank you so much, and thank you for all the interesting presentations so far. Today I would like to present to you research that I've been working on for the past couple of months in the context of my master's degree in medicine in Rotterdam. I've been conducting this research in Paris at the Craniofacial Growth and Form Lab, and it's about cranial suture closure pattern and endocast morphology in Crouzon syndrome. So I've been studying Crouzon syndrome in this work, which occurs in 1 in 23,000 births. And it's a mutation in the fibroblast growth factor receptor 2, which leads to premature suture closure. And the anomalies that are associated with Crouzon syndrome are distinct morphological features like mid-face hypoplasia and exophthalmos, but also other symptoms like hearing loss, high intracranial pressure, and cognitive impairment, as well as obstructive sleep apnea. And so the fibroblast growth receptor 2 mutation leads to premature suture closure of the cranial sutures. And if one suture closes, that restricts growth perpendicular to the suture. And according to Virchow's law, which is the most cited theory on this subject, there's increased growth along the suture. So for example, if the sagittal suture closes, you will get an elongation of the skull in the anterior-posterior dimension. But if multiple sutures close, like in Crouzon syndrome, this relationship gets more confusing, and also other possible mechanisms might be at play. So, for example, a potential role of the skull-based synchondrosis, compensatory growth far from the closed suture, or the dura mater distributing forces abnormally. So why do we want to research this relationship between suture closure and shape? As you can see, in Crouzon syndrome, there's a vastly different or variable morphology from one patient to the next. So from a normal skull, it can change into one of the skulls, which is showed on the right, which are actually real subjects in my study. And this is a result of the suture closure pattern. And this also leads to a very variable prognosis for these patients, and especially for symptoms related to shape and size. And in this research, we wanted to take a look at the endocast, which is the volume bordered by the skull base and the calvarium, which includes the brain and intracranial fluids, to really see what's going on inside the skull as a result of the suture closure. So the objective of the study was to find out how the suture closure patterns of Crouzon patients differ from those of healthy peers, and how these synostosis patterns influence their shape. And it's expected that sutures close earlier in Crouzon patients because of the FGFR2 mutation. And we expect that sutures influence shape roughly in compliance to Virchow's law. So data acquisition was done at the Necker-Enfants Malades Hospital, and inclusion of the Crouzon patients was on a preoperative CT scan under 48 months of age to really see the period where there's most steep growth. And patients had to have at least bicoronal synostosis, because this is the most common craniosynostosis pattern in Crouzon syndrome, and also to exclude any asymmetry in patients. And exclusion was based on cloverleaf skull deformity, as seen on the right here, because this morphology is so vastly different from the other ones that we see. And healthy controls were included 1 or more up to 4 years of age as well. And exclusion criteria was that the indication for a CT scan was some suspicion of a morphological change or craniosynostosis. So we started by processing the CT scans that we had for all patients and all controls, and we did this using 3D slicer. And we started by creating a skull segment using Hounsfield unit thresholding. And as soon as we had that skull segment, we could fill it in automatically and extract the endocast. And the fill-in process was automatic, but had to be corrected manually, and it had to be delineated at the bottom at the foramen magnum. And once we had all the endocasts of the subjects, we annotated them using 31 anatomical landmarks and 307 landmarks of curve. And these two were placed manually. And then we used 880 semi-landmarks of surface, and they were projected using a thin plate slice technique. And it amounted to 1,218 landmarks in total. And lastly, we wanted to quantify suture closure patterns. So we also did this in 3D slicer by overlaying the endocast segment and the skull segment. And we knew that every curve landmark, which was on a suture, had a strict amount of points every time. So when we used the layover of the skull segment and the endocast segment, we could see how many of these points were still visible. and that would lead us to a fraction of suture closure, between 1 and 0, 0 being fully open and 1 being fully closed. And it was performed on all the major cranial sutures. So when we wanted to study the relationship between shape and suture closure pattern is expected to correlate very strongly to age. So if you were to compare suture closure pattern to shape, you probably see a lot of age effects. And we also tried that, and we saw that instead of suture closure, we really got the aging effect in the shapes. So to counteract this effect, we wanted to use residuals of suture closure. And this basically means that we wanted to see how much more open or closed a suture is compared to healthy peers, so of the same age. And we did this by creating a linear model of healthy suture closure, so of all the healthy individuals, see how their suture closure was at different points in time. And then for the Crouzon patients and the healthy subjects, we calculated how much more open or closed suture was compared to this linear model. So to start with the morphometric analysis, first we had to exclude all of the other variables which were not shape, which can be done by using generalized process analysis, shown on the right here, which means isolating shape by excluding rotation and translation and scaling all subjects to the same size. And next we wanted to study how suture closure varied between our groups. So we did this for all sutures together and for each suture separately. And we used age as a covariance. Lastly, we compared shape to this suture closure pattern. So we used two-block partial least squares regression, which aims to maximize covariance between two sets of variables. And in our case, one set was the shape that we have gotten for each individual and the suture closure pattern that we had gotten for each individual. So now on to the results. First, the suture closure patterns. We saw that the coronal sutures were closed more in Crouzon population, which was not surprising as this was an inclusion criteria of our study. But it's still expected to hold in the general population of Crouzon patients because it's the most common craniosynostosis pattern in this disease. But surprisingly to us, we saw that in the metopic suture, the healthy individuals were earlier to close, especially around 1 year of age. There's quite a big difference between the closure patterns of the Crouzon and the healthy subjects. So the healthy subjects closed earlier in the metopic suture. And for the cell and the lambdoid sutures, there were no significant results found. So I'll focus on a few specific results that we found, starting with the lambdoid suture. We see here on the left the 2 BPLS of the lambdoid suture. On the x-axis, the shape score is shown, varying from a minimum to a maximum score. And on the y-axis, we see how much more open or closed the suture was compared to healthy peers. And what we really see here in the maximum score, looking at the lambdoid suture, is that there's an underdeveloped posterior segment of the endocost, which we really don't see in the minimum score. So if the lambdoid suture is more closed than in healthy peers, this posterior segment is less developed. And if we take a look at the sagittal suture and the 2 BPLS again, we see that if the sagittal suture is way more closed than healthy peers, we see an elongation of the endocost shape. And this is really in compliance to Virchow's law, stating that if the sagittal suture closes, compensatory growth will occur along the suture that was closed. So we really see that here, that in the minimum score, there's an oxycephalic skull shape, and the maximum score, there's an elongated skull shape. And I've highlighted these 2 sutures specifically because in the 2 BPLS, considering all sutures, the lambdoid sutures and the sagittals were most influential on the shape changes, as we can see here on the right. And if we look into more detail of the shape changes with the overall suture closure pattern, we see that if all sutures are closed more than in healthy peers, we still see the elongation of the skull shape, but we also see a different shape transformation, so that we really see other sutures are also still at play. But we do really see the sagittal suture influence. And in the minimum shape, we see more of an oxycephalic skull shape with a slightly upturned posterior section. So to conclude, we found that the metopic suture closes later in Crouzon patients, which was surprising because the FGFR mutation is supposed to lead to premature suture closure, but this might suggest that the metopic suture remains open and potent as a site for compensatory growth if other sutures close, which is interesting. As we saw that sutures influence shape roughly in compliance to Virchow's law, but we see that there's still a difference if you study sutures separately or all sutures together. So there's also a very important component, which is interplay between sutures. So this is relatively novel research in this field. There's no other studies that have looked at all the sutures closure patterns and their relationship to shape. And already we see promising results using the techniques that we've used now. However, we can improve and do more research using longitudinal data, because right now we used preoperative CT scans, which introduced a bias. Older patients were less severe because younger patients who presented with severe craniosynostosis and severe morphology were expected to have a CT scan earlier and be operated upon earlier. So we could not include them as older patients. And this really influences suture closure assessments and shape changes. And like I said, already very promising results. We already see influence of suture closure on the shape. But we can really look into more detail into the suture closure. For example, using 2D CT assessment, or really look in the detailed morphological assessment. Sutures are so intricate and morphologically complex that we can really get more information on this and really see when a suture is still potent and active and open or closed. So that's really excited for future research, which we're already working on. And I would like to end with this and thank you all for your attention. I'm sorry I couldn't be there in person today, but I've also included my email address if there's any additional questions later. And I think there's some room for questions now also.
Thank you very much for that really wonderful presentation. I was wondering if you had the opportunity to look at a cross-section of the suture fusion in your analysis. What we have learned recently looking at the FGF receptor mutant model, when you look at a cross-section of the calvareal bone, as you know, there is an outer and also an inner layer of this cortical bone. Seem like on the FGF mutant, the suture fusion always occurs on the dura side in this fusion process. So I wonder whether you looked at that in your sample analysis, in your data analysis.
Thank you for the question. We have not looked in that much detail to the CT scans or in those cross sections. So we really stuck to the 3D models for now. It was quite simplified, but it still gave interesting results. But it's really interesting to see maybe in the future if we can add more detailed analysis, like I said, because it sounds really interesting.
That may help to explain the mechanism why the suture fuses at a particular part of the bony structure.
Thank you. We also have an online question. Did you see any difference between the different Crouzon's mutations?
No, we didn't study that specifically. So we didn't see any differences, but that could be interesting to add in the future. Also, we encountered some problems because not all of the individuals that we included had this much detail in their genetical assessments. So we didn't know that for all individuals that we included as well.
Okay, thank you.
Yes, there is a question.
Yes, Eric Arnaud, Paris. I wanted to bounce back on this mutation difference because contrarily to APER to have only 2 known mutations, we know that for Crouzon there are more than 30 different mutations that give a variable phenotype of Crouzon, and therefore the onset of which suture, whether it starts with lambdoid or with a sagittal or with a coronal, and the age at onset of those fusions is critical to the shape. So I would strongly encourage having a correlation of the shape that you're determining with the variation of the mutations, because probably we could find something. Do you have enough samples for that?
Well, we had 56 Crouzon samples, but I'm not sure for how many of them we have detailed gene mutation information. So we will have to look into that, but it's really interesting, and I will see if I can do anything with that, because I think indeed it's really interesting to add.
Thank you.
Thank you.